Turn the music off, please. It's overriding the conference call. Turn all music off. Put your phone on mute. It's okay for a short period of time, gentlemen, but when people are listening to our conference calls and you have that going, I can't break through. Okay, ARB1, are you online, please? ARB2, are you online? Herald Clinic, are you online?
Good morning, Scott. Herald Clinic staff are all online.
How are you, Raymond?
I'm okay, Scott.
Maria, are you online?
Yes, good morning, Mr. Scott. This is Rofer with Jester. We're online.
How are you, Rafa?
I'm fine.
Hey, congratulations on passing. I haven't had a chance to talk to you.
Thank you very much.
Maria Construction, are you online?
Flying sir, this is Ramel Primailon.
Hey.
Is known there?
Yesenia, are you online?
Good morning, sir. This is Sanil from Tanzib Clinic.
Anajib, I'm not up there yet, but thank you. Marjan, are you online? Marjan 1.
Hello sir, I'm online sir.
Pat, Marjan 1?
Yeah, online.
Okay. Marjan 2.
Sir, this is Cecil from Margin 2.
Okay, thank you. Marjan 3. Impan 2. Star 201.
Star 201.
Assassinea, Ghost 4, are you online?
Sir, this is Ping. I am online.
Hey,
Morning sir.
Okay, Tanajib, thank you. Zuluf, are you online? Zuluf 1, sorry.
Lulu.
Zuluf 2.
Lulu 2.
Zuluf 4.
Yes, it's online, sir. It's Donato Zulu 4 Clinic.
Thanks.
Online discussion, this is everyone that lines.
Star 010. Handwigs are probably not. 102. 103.
151.
151.
52.
152. 153. Shaber, are you online?
Online, Mr.
Hi Manny, how are you? Terry, are you online?
Good morning, sir. This is Gershom and Carlo from Berry.
Good morning, Barry. Gershom.
How are you, sir?
Ryan ITC, I just spoke to you on the phone. Are you online yet? Yeah, I don't think he is either. Halta, are you online?
Good morning, sir. This is Emmanuel and Biju from Hota, sir.
Good morning, Emmanuel. Grace.
Good morning, Gershom.
Morning, sir. Shalmon and Abram online, sir.
Good morning, gentlemen. Since you're doing your presentation today, I think it's only fair. I'm station 3.
Online.
I'm station 6. Annie, you there?
Online.
I'm station 10, are you there?
Morning, sir. This is Maksud and Marco from PS10 Clinic.
How are you, gentlemen? Where's Babu?
Up on vacation, sir.
Sir, Papu is on vacation, sir.
Oh, okay.
Hurry up.
Thank you. Yeah, he's talking on Sunday. We had refinery.
Good morning, sir. This is Arun and all staff are online.
Good morning, Aaron. Shedgum, are you online?
Yes, sir. Good morning. This is Duncan and Art online.
Good morning, gentlemen. Okay, SSP1, are you online?
Sagar online.
Jeddah. ITC, sorry. No one there yet. Jeddah Bulk Plant.
Morning, sir. This is Edgar Gerardo, sir. Good morning, sir.
Good morning, Edgar. Jeddah Refinery.
Good morning, sir. This is Injumar and Mon online now, sir.
Congratulations, gentlemen. SSP5, are you online?
Good morning, sir. Online, sir.
How are you, sir?
I'm fine, sir.
Okay, are you still having troubles with your driver? I will come back to that. SSP6.
Online.
How are you, sir? Who am I talking to?
What is that?
SSP6 is there.
Online.
Who's online? Who's the name?
It's online now.
Abdul Jabbar and Sajeev.
Okay, thank you, gentlemen. Adina, are you online, Ralph? Roy. Bamboo, are you online?
Good morning, Scott. This is Jerry and Yanbu staff is on the line.
Hi, Jerry. How are you?
Fine, Scott. Thank you.
Okay, gentlemen. We need to move straight into the presentation for it's about Marfan syndrome, which is a very significant incident that is available to us, and it's a very excellent presentation which is done by one of our staff members, so we need to follow through and listen to it, please.
Good morning, sir. This is Dennis online from Corsania Clinic.
Thanks, Dennis. How are you, sir?
Fine, sir.
Just Everyone, please be aware I am doing code blue practices wherever I go, and I am finding that people are not maintaining their BLS. Please be aware it has already been invoked about the BLS payment. If you do not know your knowledge and we offer you a course and you do not attend or you fail to remember the information, you pay for your BLS. Okay? I cannot make that any more clear. Alright, sorry, somebody has already been charged 400 reals, and this will continue until you start making sure you practice your code blue. Alright, let's get on to this presentation, please. Over to you, Shalman, if you're there.
Yes, sir. Mr. Abram is presenting Marfan syndrome for us, sir.
Okay, go ahead, sir.
Good morning, sir, and all of my friends. Today, my topic of presentation is eyes, heart, and blood vessels. The condition is caused by change in a gene which produces fibrillin. Fibrillin is a fine fiber which acts like a Marfan syndrome is an inheritable condition that affects the connective tissue. The primary purpose of the connective tissue is to hold the body together and provide a framework for growth and development. In Marfan syndrome, the connective tissue is defective and does not act as it should. The connective tissue is found throughout the body. Marfan syndrome can affect many body systems including skeleton, nervous system, skin, and lungs. Incidence. The Marfan syndrome is a rare disease which affects the men, women, children all over the world, regardless of their age, race, ethnic background. The child of a person who has Marfan syndrome has a 50% of chance of inheriting disease. Some of the characteristics of the Marfan syndrome. Marfan syndrome affects the different people in different ways. Some people have only mild symptoms, while others are more severely affected. In some cases, the symptoms progress as the person ages. Some of the general characteristics are highly arched palate and crowded teeth, nearsightedness, lens dislocation, anal chest or pigeon breast, scoliosis, fat feet, thin narrow face, micronatia or colobomorphitis, hypertonia. Some of the systemic findings in Marfan syndrome are in the skeletal system. The people with the Marfan syndrome are typically very tall, slender, and loose-jointed. Since Marfan syndrome affects the long bones of the skeleton, arms, legs, fingers, and toes may be disproportionately long in relation to the rest of the body. The person with the Marfan syndrome often has a long, narrow face, and the roof of the mouth may be arched, causing the teeth to be crowded. Other skeletal abnormalities include the sternum, that is either protruding or indented, curvature of the spine, and it could be depressed inside. And in the symptomatic problems in the eyes are lens dislocation. More than half of all people with the Marfan syndrome experience dislocation of one or both lenses of the eyes. The lenses may be slightly higher or lower than the normal and may be shifted off to one side. The dislocation may be minimal or it may be pronounced, and yes, retinal detachment is possible serious complication of the disorder. Many people with the Marfan syndrome also nearsighted, and some of can develop glaucoma or cataract. In heart and blood vessels, most people with the Marfan syndrome have abnormalities associated with the heart and blood vessels because of faulty connective tissues. All of the aorta may be weakened or stretched. A process called aortic dilatation. In aortic dilatation, increases the risk of that aorta will tear or rupture, causing serious heart problems and sometimes sudden death also. In some cases, certain valves may leak, creating a heart murmur which doctor can hear with the stethoscope. Some leaks may not be resulting in symptoms, but larger ones may cause shortness of breath, fatigue, and palpitations. In nervous system, the brain and spinal cord are surrounded by the fluid contained by a membrane called the dura, which is composed of connective tissues. As the people with the Marfan syndrome get older, the dura often weakens and stretches, then begins to weigh on the vertebrae in the lower spine and wear away the bone surrounding the spinal cord. This is called dural ectasia. These changes may be caused only mild discomfort or maybe lead to radiated pain in the abdomen. 20 people with the Marfan syndrome develop this problem. In spontaneous unilateral pneumothorax, air escapes from lung and occupies in the pleural space between the chest wall and the lung. The lung becomes partially compressed or collapsed. This can cause pain, shortness of breath, cyanosis, and if not treated, death. Although connective tissue abnormalities make the tiny air sacs within the lungs less elastic, people with the Marfan syndrome generally do not experience typical problems with their lungs. However, these tiny air sacs become stretched or swollen, of lung collapse may increase. Rarely, people with the Marfan syndrome may have sleep-related breathing disorders such as snoring or sleep apnea. The diagnostic evaluation. There is no specific laboratory test such as blood test or skin biopsy to diagnose Marfan syndrome. The diagnosis of Marfan syndrome is made on the basis of the family history and the physical examination, focusing particularly on the eye and heart. Tests such as echocardiogram are often helpful for making a diagnosis. Although it is possible to do genetic tests for Marfan syndrome, in practice this is still difficult and is not routinely done at present. The treatment, according to the system-wise, in cardiovascular problems, for medical management for the cardiovascular problems, doctors often prescribe blood pressure lowering drugs to help prevent the aorta from enlarging and reduce the risk of dissection, even though your blood pressure may be normal. The most common drugs used are the beta blockers, which cause your heart to beat more slowly and with less force to reduce the risk of aortic dissection and rupture. The second drug of choice is calcium channel blocker or angiotensin covering enzymes AC inhibitor in case of any adverse effect of beta blockers. Surgery in surgical management for the cardiovascular problem. In life-threatening situations such as aortic dissection or rupture involving the ascending aorta, the surgery is the only treatment of choice. Replacement of the damaged section of tibia, tube graft when there is no damage to the aortic valve. Replacement of the damaged section of the aorta and replacement of the aortic valve. The management for the skeletal problems. Scoliosis. For some children and adolescents, doctor may recommend a back brace, a custom-made plastic garment extend from the shoulder to the waist. Although it can't permanently straighten the spine, it may help to stop the spinal curvature becoming worse while children are growing. The most common surgical procedure for the scoliosis is posterior spine fusion and instrumentation. For the treatment for the concave chest. And concave causes the breathing difficulty when surgery may be the option, which consists of rising of the sternum and ribs. Treatment for the eyes. For the dislocated lens. In young children, a dislocated lens is treated with the glasses or contact lens. Adolescents who find visual field to restricted intraocular lens implant can be performed. For the glaucoma, disease can be controlled with the early detection and treatment. Eye drops, oral medications or surgical procedures can prevent or slow further damage. Patient may need new treatment for its rest of life. The cataract, surgical removal of the cataract is the only panacea for the cataract. For the lungs, the spontaneous pneumothorax, chest tube is an appropriate initial therapy. These are the treatment sections for the Marfan syndrome. Thank you very much for all my friends and myself.
Thank you for your presentation. Just a couple of quick questions. One, I'm not quite sure at the moment, a little bit difficult to hear here. One of the major complications associated with Marfan syndrome is smooth muscle disintegration. Okay, so the patient will have a cardiac arrest and die rather rapidly. The other complication associated with Marfan's is spontaneous pneumothorax. Did you go into that? Sorry. Okay, so what are the signs and symptoms of spontaneous pneumothorax then?
In spontaneous pneumothorax, the person may get the breathing difficulty. He may have
Shortness of breath, cyanosis, and if not treated, the death will be.
Okay, now I want you to be more clear on that, gentlemen. When you say shortness of breath in the last hour, the last 15 minutes, what do you mean? Do you know?
Patient may feel difficulty while taking deep breath or for coughing or for deep breath.
Okay, I'm going to open the question up to everybody. Can anyone tell me what a spontaneous pneumothorax is? Yes, it's shortness of breath, but the patient will have something else occurring at the same time. If I go to Harad, Raymond, just because you're at the top of the list, can you guys tell me what you think would be another issue there?
Come again, Scott?
Okay, I'm just talking about a spontaneous pneumothorax. When you have a spontaneous pneumothorax, yes, you have difficulty in breathing, but there's something which also presents at the same time. Do you know what that may be?
Yes, Scott. Patient presents a distended neck pain.
Sometimes they can if the spontaneous is that large, but if it's a small spontaneous collapse, which is a possibility, you can have small collapses of your lung. Okay, so something else. Can you think of something else with that, as not being that dramatic as distended neck vein?
Tracheal deviation as such.
So you can have that as well, but something more basic. We go to Shaber. Manny? Hello, Shaber, can you hear me? Okay, Jerry and Yambu, can you guys hear me? Jerry, can you hear me?
Yes, Scott, this is Julian line.
Okay, so Ken, I don't know if you've got Dr. Aljed there at all, but there's something which happens with the spontaneous pneumothorax.
He's present, Scott. Oh, I think he gets pain.
Chest pain.
Yes.
Hey, excellent. Thank you very much.
Hello.
You understood that. Yeah, chest pain is one of the first things the patients will present with.
Hello.
Hello, Dr. Aljed. How are you, sir?
How are you? Nice to hear you.
Okay, sorry if I'm talking too quickly. Tell me to slow down.
Yes, what is it?
Okay, so if a patient has a spontaneous pneumothorax,
Yes.
they will present with a sudden onset of chest pain. Is that correct?
Yes, that's correct.
Okay, so that's what I want everyone to understand. When you're talking sudden onset of chest pain, we mean spontaneously. In the last...
That's right. And I read the presentation about Marfan syndrome.
Okay, yeah.
We should orient all of our lecture. We look at it through the remote area clinic.
Yes.
You see, we have two conditions. One is extremely rare, and the other is not rare. Sometimes it is encountered. And these are, number one is a spontaneous pneumothorax. If a young man, he's very tall, with finger tall, and he said, I have chest pain, is a stabbing-like pain, and shortness of breath, this is an emergency. We have to suspect a spontaneous pneumothorax until proved otherwise. We check the trachea, we check the efficacy.
10-minute warning message.
We listen to
The conference ends in 10 minutes.
We listen to the breathing sound and send him, or we pass chest tubes.
Right. So, another thing that, out of interest for everybody to know, sometimes
Yes,
a spontaneous pneumothorax may not be so large that we have to put in a chest tube.
Yes.
Because if we introduce a chest tube, we may increase the size of the thorax collapse itself. There are times we may treat it what they call conservatively and see how
Yes, absolutely. It depends. There are three graded, grade 1 and 2 and 3. Grade 1 is mild, but it should, in any case, the patient should be put under close observation.
Very good, yeah, they should.
You see, close observation. So the point is that either you send him to the hospital quickly to take chest x-ray and assess the level of collapse of the lung and the amount of the air. This is one. But if it is massive, then there is no alternative except to pass chest tubes if you can. All right. But the fact remains that this is an emergency. Tall chap with chest pain, stabbing, and dyspnea mean pneumothorax until proved otherwise.
Right, very good, and that's what I was trying to get through.
Absolutely. And I appreciate your emphasis on this point.
So, Sherman, do you understand that?
Yeah.
Yes, sir. Okay, so what we're saying about, yes, your patient will have a collapse, but if they start getting cyanosed fingers, that's a very latent sign. You really want the spontaneous sudden pain that they do get.
Absolutely. High index of suspicion.
Okay, and it's very quick. Now, there's other conditions which may introduce a spontaneous pneumothorax here. For example, the dust in the air can create a spontaneous pneumothorax, gentlemen. You need to be aware of that.
Yes. So, for example, emphysema. People with emphysema, also most of our patients are young people, but people with emphysema, barrel chest, chronic bronchitis, they have some small bully in the lung.